Thank you for viewing this program. This module discusses robotic prostatectomy. Radical prostatectomy involves the complete surgical removal of the prostate, along with its surrounding structures. It is indicated for the treatment of prostate cancer, in an attempt to cure or help control advanced prostate cancer. The procedure can be done by making an incision or cut in the lower abdomen, called an open prostatectomy, or via laparoscopy, which involves surgery performed under video guidance using special instruments. Laparoscopy can be done with or without robotic assistance. The procedure of open prostatectomy is discussed in detail in a separate module. The goal of a radical prostatectomy is to remove the prostate gland, seminal vesicles, and ejaculatory ducts, as shown by the dotted line on the left. After this, the neck of the bladder is then sewn back onto the urine channel or urethra, as shown on the right. So who are good candidates for robotic prostatectomy? Most patients with the diagnosis of localized prostate cancer and considered to be in good general health can be considered for the procedure. By localized, we mean that the surgeon feels that there is a good chance that the cancer is contained within the prostate and has not yet spread beyond its borders. This determination is made by considering a patient's PSA level, his biopsy findings, and the stage or extent of tumor based on the digital rectal exam. There are also those who may not be considered good candidates for robotic prostatectomy, including those with uncorrectable coagulation or blood clotting defects, severe heart or lung disease, and some rare patients with significant active bowel problems. Other patients who may be at increased risk for complications include the elderly, those who are severely obese, and those with a history of previous extensive or multiple abdominal or pelvic surgical procedures. These patients should have a detailed discussion of the risks and alternatives to surgery with their physician. In preparation for surgery, several additional tests may be performed. These include tests on the heart, lungs, and bowels. An electrocardiogram, or ECG, chest X-ray, and blood work will take place before surgery. The bowel may also be prepped or cleansed prior to the procedure. Due to the addition of air to the abdominal cavity during the procedure and its impact on the heart and lungs, some patients may require stress testing and pulmonary function tests for the lungs. It should be noted that no aspirin-containing products, or medications that affect blood clotting should be taken prior to surgery. Your doctor or hospital will advise you precisely on what medications need to be stopped and when. Patients should shower the evening before surgery. They are also advised not to eat or drink anything after midnight the night before surgery, or 8 hours prior to the procedure if the surgery is going to be performed later in the day. Try to get plenty of rest leading up to surgery, and on the day of the operation, please arrive early to the hospital. Once in the operating room, an intravenous or IV line will be started if not done already. A spinal anesthetic, pain-relieving medications injected into the back, may also be given. You will then be put to sleep by the anesthesiologist, and a breathing tube will be introduced. This is called general anesthesia. Special compression devices and/or stockings will be placed on the legs to help prevent blood clots. Other tubes and monitoring lines may then be placed, including a catheter into the bladder to monitor urine output, and rarely an arterial line in your wrist to monitor blood pressure. Other monitoring devices are also used to check your level of blood oxygen, your temperature, and your level of anesthesia, among other things. The doctors and nurses will then carefully position you on the operating table in such a way as to optimize the ability of the surgeon to carry out the operation. For a robotic prostatectomy, you will typically be placed flat on your back and the bed will be tilted down towards the head. Once positioned, the skin is cleaned with an antibacterial solution, and 5 to 8 small pencil-sized openings in the abdomen called incisions are made through which special instruments are placed. After preoperative preparation is complete, patients are ready for surgery. Robotic prostatectomy incorporates a state-of-the-art surgical system that helps your surgeon see vital anatomical structures more clearly and to perform a more precise surgical procedure. After the surgical instruments are placed into your body, the surgeon works from a special console, as shown in the image, to guide the instruments and perform the operation. The robotic instruments do not perform any functions on their own without the surgeon guiding them. Once the surgical space is accessed, there are 4 main steps of the operation that may follow: lymph node dissection, nerve sparing in select men where it would be appropriate and not jeopardize cancer control, removal of the prostate, and reconnecting the bladder to the urethra. The pelvic lymph nodes are the usual first site that cancer goes to if it spreads beyond the prostate. Removing these provides information on the extent of cancer and can help to control it. It is important to understand that a formal lymph node dissection is not required in all cases, and individual situations and surgeon preferences may vary. Once the lymph node dissection is done, removal of the prostate begins, and in the early part of this, nerve sparing may be performed. In this process, the penile or cavernous nerves can be released from the prostate and spared from injury to preserve erections. Depending on the situation, one or both sides may be spared. This step can improve the chances of recovering good erections after surgery. However, it does not guarantee recovery of erections, as there are many other factors that come into play. It is important to understand that not all men are candidates for nerve sparing, and your surgeon will discuss your situation with you. Following nerve sparing, the prostate is completely disconnected from the urethra and bladder and carefully lifted away from the rectum. The vas deferens are cut, and the seminal vesicles are removed with the specimen. Once the prostate is removed, the opening to the bladder, called the bladder neck, must then be sewn back onto the urethra to recreate the urinary tract. This is done over a catheter, which keeps an open channel for urine drainage while things are healing. It may be your surgeon's practice to leave a small drain tube in the pelvis after the operation, to be sure that no blood or fluid accumulates in the days after surgery. This drain is usually removed within 1 to 3 days after the operation. Following surgery, you will have a catheter or tube in the bladder that allows the connection between the urethra and the bladder to heal. This catheter is typically left in place for a few days to a couple weeks after surgery. This is dependent upon the quality of the connection, surgeon preference, and when the drainage of urine and blood diminish. The hospital staff will teach how to manage the catheter at home. The tiny pencil-sized openings are closed with stitches or staples, depending on your doctor's preference. Most stitches will dissolve and do not need to be removed. Other sutures or tiny staples may need to be removed in 7 to 10 days in the doctor's office. Most men can get out of bed the day after surgery and start walking around. This helps to prevent blood clots in the legs and other possible complications. Most men are discharged from the hospital once they are able to walk, tolerate food or fluids, and their pain is well controlled with oral pain medication. It is advisable to avoid strenuous activities for a few weeks following surgery, as recommended by your doctor. For most patients, robotic surgery offers several potential benefits over open prostatectomy, including smaller incisions, less blood loss, and fewer transfusions, quicker recovery time, shorter hospital stays, and decreased pain and need for pain medication. There are some potential disadvantages of robotic prostatectomy as well. It can be a longer procedure than open prostatectomy, and the patient must be positioned with his head in a downwards position for a prolonged period, which can be a problem for certain patients. The procedure requires costly equipment and technical expertise, which is not universally available, and rare technical challenges with the equipment may arise. Finally, there are some other unique risks of the procedure which are mentioned later in the program. It is important to understand, but not overestimate, the impact of the robot in performing these complex procedures. Robotic surgery enhances surgical capabilities by improving visualization and enabling the performance of complex movements through tiny surgical openings. The system, however, cannot be programmed to do the surgery itself, nor can it make decisions on its own. It is therefore the surgeon whose skill with the robot ultimately determines the outcome of the operation. Another important point not to overlook is that despite the so-called minimally invasive nature of the surgery, it is still a major operation that takes some time to recover from and can be associated with certain complications in some cases. In good hands, there appear to be at least similar results to other forms of radical prostatectomy for cancer control and functional outcomes such as erectile function and urinary control. Cancer outcomes, such as the positive surgical margin rate and survival, will depend on several factors, such as the tumor stage and the surgeon's skill and experience. Despite the greatest care taken by your surgeon and the medical team, complications can occur during and after any operation, and robotic prostatectomy is no exception. The next several slides will review these potential risks in detail. The risk of death from bleeding, heart attack or heart failure, stroke, blood clots in the lungs, pneumonia, and other factors remains very low and would be considered extremely rare. Significant bleeding is a risk during any operation. However, bleeding is minimized with the use of robotic surgery. Average blood loss is less than 500 milliliters and typically less than 100 to 300 milliliters, which is less than with open surgery. Transfusions are required in less than 1 to 3% of men having robotic prostatectomy. In many institutions, transfusions are extremely uncommon. In the operating room, there are a few potential complications that could occur that are specific to laparoscopic or robotic surgery. In the rare event of complications such as bleeding, malfunction of equipment, or great difficulty proceeding with the operation, the surgery may have to be converted from a laparoscopic or robotic one to an open operation. This may occur in approximately 0.5%, ranging from 0 to 1.1% in different reports. Another special complication that may rarely occur is injury to the bowels or other structures caused during placement of the trocars, which are used to place the ports or sheaths that the robotic instruments are placed through. This happens in less than 0.5% of cases. Other rare complications that can happen in the operating room are listed here. Rectal injury can occur in the process of separating the prostate from the rectum. This complication may be more likely with prior radiation or previous prostate or rectal surgery. Rectal injuries are most commonly fixed at the time of surgery with no consequences. However, if they are not recognized, they can rarely later lead to a connection between the rectum and urethra called a fistula. The risk of injury to the tubes that drain urine from the kidney to the bladder, called the ureters, is very low, less than 0.5%, and is more likely to occur with advanced tumors. A nerve in the pelvis called the obturator nerve may rarely be injured during lymph node dissection. Anesthetic complications are also very rare. Modern anesthesia has become very safe, and this should be discussed in further detail between you and your anesthesiologist. Lung and heart complications can rarely result from general anesthesia, while headaches can be a rare complication of spinal anesthesia. There are other complications that may occur in the first few days after surgery. Heart problems such as heart attack, heart failure, or rhythm changes are uncommon after prostatectomy, but do occur on occasion. Specifically, the risk of heart attack is about 0.5% or less. Lung problems may also rarely occur, as the lungs do often become partly collapsed after a general anesthetic, and this is called atelectasis. For this reason, you will be encouraged to do breathing exercises after surgery. Pneumonia is an uncommon complication of prostatectomy as well. Ongoing or delayed bleeding is a rare complication and may require return to the operating room. Importantly, blood clots in the legs, called deep venous thrombosis or DVT, or in the lungs, called pulmonary embolus or PE, may occur from poor venous circulation during and after surgery while the patient is immobile. This potentially fatal complication can occur with any operation, and measures are taken to prevent it, including the use of special compression devices on the legs, drugs to prevent clotting, and early mobilization. This problem may occur while in hospital or rarely after discharge home. After robotic prostatectomy, the risk of DVT is about 0.5%, and the risk of pulmonary embolus is 0.2%. Infections of the bladder, wound, abdomen, bowels, or intravenous line sites may occur in 1% of cases. Prolonged drainage of urine from the drain tube may occur in 1 to 10% of radical prostatectomies. This is usually caused by a persistent opening at the site of the connection between the bladder and urethra that allows urine to drain out through it. This problem usually resolves in time, and only very rarely requires reoperation. It may, however, require that the drain tube and/or catheter stay in for a longer period of time. Slow return of bowel function occasionally occurs after prostatectomy, and this may prolong the hospital stay slightly until normal function returns. Swelling of the genitals or lower limbs may occur after surgery, and this is usually caused by retention of carbon dioxide gas that is used to create the space for surgery, or from temporary obstruction of lymph drainage. Catheter problems can be disturbing early after surgery, particularly if the catheter gets plugged, unexpectedly falls out, or gets pulled out too early. If the catheter stops draining, it may require irrigation. Call your doctor's office if you have any significant catheter problems after you go home. If lymph node dissection has been performed, some lymph fluid may collect in the pelvis and form what is called a lymphocele. These occur in about 0.1 to 5% of cases where this is done, and may require a drain tube to be placed, or rarely surgery. Similarly, if urine leaks out around the anastomosis where the urethra and bladder are reconnected, it may also collect in the pelvis, forming a pocket of urine called a urinoma. Finally, problems with the incisions, such as infection, wound breakdown, or herniation, may occur in up to 1% of cases. The important subject of erectile dysfunction and its relationship to all prostate cancer treatments is discussed in detail in its own separate module. A few key points are reviewed here. The likelihood of erectile dysfunction after prostatectomy is difficult to predict for any individual, and depends on a number of different factors, especially the age, the quality of erections before surgery, and nerve sparing. Reflecting this high degree of variability, the chances of maintaining erections after surgery are reported from 14 to 97%. Many men will require the use of medications called phosphodiesterase inhibitors, such as Cialis or Viagra, to assist with erections after prostatectomy. With nerve sparing, erectile function will typically return 10 to 18 months after surgery, even earlier for some and even later for others. Some reports have even shown men experiencing return of function up to 4 years after surgery. Many good treatments are now available to assist with erections, and many doctors will recommend beginning treatment early while waiting for nerve function to recover. Use of oral medications or injections early after surgery may help speed the return of erections after surgery, although this remains unclear. This is discussed in more detail in a separate module. Making lifestyle changes like stopping smoking, losing weight, eating well, and getting regular exercise can also help to maximize erectile function. Men have 2 levels of urinary control. 1, a so-called internal urinary sphincter, or valve, and 2, an external urinary sphincter, which is the one we can tighten to stop urinary flow. Prostatectomy removes the internal valve mechanism, so that a man must then rely on the external sphincter for control. Because prostatectomy can also weaken external sphincter function, loss of urinary control called stress incontinence can result. This topic of urinary control after prostate surgery is also discussed in greater detail in its own module. When the catheter first comes out, leakage of urine is common. Most men, however, recover good urinary control very quickly. Full control may take up to 1 to 2 years to regain, with most achieving it in the first 3 to 6 months. It is thought that pelvic muscle or Kegel exercises may speed recovery of urinary control. Overall, about 5 to 15% of men may continue to use pads for protection against some amount of urinary leakage after surgery. In the rare cases of significant leakage, good treatments are available. The final late complication to note is that of scar tissue buildup at the bladder neck, called a bladder neck contracture, which occurs rarely after robotic prostatectomy. This may result in slowing of the urinary stream, difficulty emptying the bladder, or incontinence. It is usually treated with a simple outpatient procedure to cut or dilate the scar tissue. It is important to contact your doctor if any of the following occur after surgery: fever, nausea and vomiting, uncontrollable pain, cough and shortness of breath, swelling and tenderness of the legs, chest pain, problems arising from the catheter or difficulty passing urine, and if the incision site becomes red, tender, or swollen. In summary, prostate cancer is a common condition that will affect a considerable number of men during their lifetime. However, many treatment approaches are available to help manage the disease. Robotic prostatectomy is one of these approaches and is discussed in detail in this module. It is the complete surgical removal of the prostate along with surrounding structures including the seminal vesicles and ejaculatory system. This operation is considered a major surgery, and there are important risks and complications to understand. Overall, robotic prostatectomy is a safe procedure associated with a high degree of satisfaction. Thank you for viewing this educational program.